very interesting, but you know.
So here, final conclusion. I think we always have to evaluate the patients individually. It should be done multidisciplinary, and there is a lot of conditions that should be met. I mean, you have to talk to your surgeon, and the final answer that you have to give is how are you going to have your patient survive until his 70s and 80s. And obviously, we will need to coordinate all our results so that in a few years from now we will be able to say this valve will last for so much time in such a patient. Thank you very much.
Many thanks. We have no time. Please, Gianfranco.
Okay. So welcome back. We have finished.
Like to know what happened.
Yeah, we have changed a bit our strategy. This is why we asked for a connection, earlier connection. In fact, we have left you when we had this 35 millimeters gradient across the horizontal aorta, and we thought that probably a distortion of the aortic arch related to the stiff guide wire could be the cause of that. So we placed a pigtail catheter in the ascending aorta without any wire, and the gradient dropped down to 11 millimeters of mercury. We had also a nice 3D reconstruction we would like to show you. Gregor?
So what Gianfranco said, the change of anatomy, what we have is the wire position before we stented. So we have the wire here and the other one are the pigtail markers which are visible. If we now just compare this and compare the shift of the metal to the interventional situation, then take a look how the wire and the stent and the anatomy, how the metal changes. If we now take the same game pre-post and show what the vessel was before, with the descendants included, and now we show how anatomy changed, especially at this point where they did the wrist draw measurements, then we will see that this is a post situation, and the post situation compared to the pre, this notch, this critical point, this artificial Gothic, however you call this, changed just due to the metal.
Yeah, so as Allison astutely pointed out, when we did the little angiogram, it looked like it had turned into a Gothic arch, which you know is the tenting. And of course, Gothic arch is a term that MRI people use, not angiographic people use. But you can see very nicely there that Gregor's showing that how that part of the arch was tented up and increased the gradient. So after the dilation to 16, which you can see the stent looks very nice at 16, changed and distorted the arch, and so it's more like a 10 or 11 gradient, which we felt was okay. And Lee was talking about, you know, give this boy time, but you know, unfortunately, he has still a very significant degree of aortic regurgitation. So leaving him with too much of a gradient down the road may not be wise, but at this point in time, we thought this is a very nice result. He could have blood pressure in the arm and leg very easily measured, which across his arch, do exercise and see how he does.
Okay. Yeah, you have seen post-dilation of the stent and then post-dilation on the distal part, and this is the pigtail catheter into the ascending aorta. I would like to show the 3D injection also. Yeah. You see?
Yes, if you could just show us the rotation very quickly, then we can move to our next site.
Yeah,
that's a very nice result.
Lanjo. Yeah.
Maybe if we wait long enough, we will be able to have the native valve TAVR for the boy.
Yeah.
Yeah, maybe.
Maybe. Okay, thank you.
Very good.
Beautiful. So we are back with the covered stent in place. Perhaps you would like to fill us in